So I am going to present two cases. So this is a case with a primary trauma X-ray. How many of you agree that there is a fracture in his? Yes, so we can see that there is a, we can see the soft tissue swelling over the lateral condyle, okay, and obviously there was tenderness and a small fracture is seen. So this was the primary C-arm view. So how will you proceed in this case? How many of you will go for MRI? Ashish? Any other thing? So I did a stress view, and as you said, internal rotation, 30 degrees internal rotation view. Okay, but then I went on for an arthrogram. Sandeep sir, arthrogram?
Yeah, internal rotation view nowadays is the gold standard to look at a lateral condyle fracture and then classify by Song's method.
Yeah.
If the gaps are more than 2 millimeters and they are wider equally, medially and laterally through the fracture, then probably the hinge is broken. But otherwise, an arthrography is the way to identify if you don't want to do an MRI.
Yeah. So I would like to ask the audience, how many of you will go for just close reduction and pinning, or just only with a cast, or would you like to open this? Close reduction only, or close reduction with K-wire? Okay, but how will you confirm? So if the fracture is, most important thing over here is that if the fracture is going intra-reticular, it may land up into a non-union. So we went ahead with a arthrogram. So that's the needle entry. That's the arthrogram which is showing dye in the fracture. And this is how it is. So if we can see in the second picture, we can see the epiphysis which is not actually seen on the X-ray, and as the dye is not completely crossing into the joint line, this case can be managed with a close reduction and K-wire, but it has to be fixed. So this is how it is. If the arthrogram stops short of joint surface, and whether the arthrogram dye is going through the joint surface, that is what we have to see. And that decides whether it can be treated closely only with a cast or whether it needs a fixation. So this is another case. I'm sorry for that poor X-ray, it was many years back. And it was treated only with close reduction elsewhere. And after 4 months, you can see that the X-ray is showing non-union. And the third X-ray is showing the non-union after 7 years. So how would you like to process? Ranjit sir?
What is the range of movement? It will depend upon how...
Almost normal, almost normal.
Okay, if the range of movement is normal, you could consider fixing it in C2 and maybe bone grafting, but a reduction would maybe cause more stiffness.
Yeah. Samir?
Yeah, so if you see the AP view, there is a bone loss over there. So I would like to put in a small bone graft at the metaphyseal end and just fix it in C2 just to prevent future problems.
Ashish, how would you like to proceed with the dissection?
Yeah, so I agree with Samir. It's nothing intra-articular, just stabilization of the metaphyseal part.
Yeah. So that's what I also did. So the most important tips in this is that don't open the fracture site. Always go for anterior dissection. Don't attempt anatomical reduction. So it's an in situ metaphyseal fixation with a bone graft. So we took the bone graft from proximal ulna and fixed this, and it went on to heal well with full range of motion. So most important thing in lateral condyle is that proper imaging is must to avoid missing the fracture. Opposite elbow X-ray is a friend. Stress views and 30-degree internal rotation views always help us. Conservative management or close reduction and K-wire only with an arthrogram. When in doubt, don't hesitate to open. Don't hesitate to take down the common extensor origin by a few millimeter to get a better view of reduction. The lateral condyle has its blood supply from the posterior surface, so don't dissect posteriorly. Divergent K-wires as the fragments tend to slip over parallel wires. Check intraoperative stability and always protect till clinico-radiological union. Thank you.